Welcome, everyone. I'm Anne Goebel. I'm the Nurse Wellness Coordinator at the New Canaan YMCA, and I represent Stamford Health. We are so very fortunate to have Dr. Michael Parry speak with us today. Dr. Parry is Chief of Infectious Diseases and Microbiology at Stanford Health. He will tell us today all we need to know about the COVID-19 vaccine, followed by a Q&A. I think many of your questions may be answered during Dr. Parry's talk, but you can type them in and we will get to them. We will post this webinar on our website for those that you have missed it. So, Dr. Parry, I'll let you begin.
Thank you, Anne. Pleasure to be here. Let me share my screen. How's that? Can you see the slides well?
Yes.
Good. Okay, so the topic is in the news, and I know everybody has their own thoughts and opinions, and I'd just like to share with you what I feel is important about the vaccine, and share with you what Stanford Health has done in order to get vaccine out into the community and hopefully see the light at the end of the tunnel and get some impact on this pandemic. So I thought I'd just kind of start at a high level and look at the map that is updated daily on the Johns Hopkins website. You can see that globally, we are talking about over 100 million cases of COVID-19 with 2 million plus deaths. In the US, unfortunately, has the dubious distinction of leading the world in the number of cases with 26 million cases and almost 500,000 deaths. Now, to put this in perspective, think about influenza. The annual number of cases of influenza in the US are somewhere between 20 and 40 million, depending on the year. The number of deaths are in the 30 to 40,000 range. So we're looking at a huge difference in magnitude of morbidity and mortality compared to the standard influenza season. And if you look at the bottom right of this graph, you see the sort of global trajectory of cases. This is cumulative cases, but you can see there's no evidence of any plateau happening here. An unfortunate comment on the fact that the pandemic is still very active, ongoing, and really shows no signs at the moment of tapering off. You recognize the state of Connecticut, of course. This is a frequent update that's published by the state of Connecticut Department of Health, and it looks at the case rates per 100,000 population by town. I highlighted New Canaan because obviously it's pertinent to today's discussion. You can see that almost every town and every county in the state of Connecticut is red, which is more than 15 cases per 100,000 population. A few isolated spots of lower rates, but there's really, throughout the state of Connecticut, highly prevalent COVID-19 case rates. And New Canaan comes in at 27 per 100,000 population. The city of Stanford, by comparison, runs in the low 50s, I think 51, 52 for the same time period. This is a graph that I keep up to date every week. It represents all of the testing that we have done for COVID-19 in the city of Stanford. And most of these will be community tests, our drive-through testing units, referrals to our laboratory, and it represents COVID PCR testing. And you can see that in March, April, and May, we had astronomical numbers of tests, 100 to 125 positive tests every day. Then in the summer, things waned. We saw really a very quiet summer, 10 to 20 positive cases a day. And then despite wearing masks, social distancing, lack of travel, decreased gatherings, restaurants closed, et cetera, we saw a surge in COVID-19 cases, so that now in the last few months, we've been seeing 50 to 70 positive tests every single day. A bit of good news, the month of January seems to be tapering off a little bit, and our numbers are down. But still, we're looking at 10 to 15 to 20 new positives every day. And most of these, again, are community tests. Some are hospital, but mainly from the community. Our overall rate is 2.4%, and the average in Connecticut is 4.3%. So you can see that the impact this has made, and it contrasts with the green line in this graph, which is influenza. And in December, January, February, we saw a pretty brisk influenza season, but it compares incredible contrast to the COVID outbreak. Influenza is dwarfed by the number of COVID cases. In terms of hospital rates, hospitalizations due to COVID, this slide shows the state census and the Stanford hospital census. You can see March, April, and May, and you can see where we are now. Certainly a lower level of activity, but compared to the summer months when there were times at Stanford Hospital when we had 0 cases of COVID in the hospital, we are running now between 30 and 40 a day as our census, certainly less than the 150 peak that we had in April. But still, given the high numbers of cases in the community, the hospital obviously reflects the fact that some of these patients get very sick. Some of them will die. Some of them will be in the ICU and on ventilators. So it continues to be a huge impact on our hospital system, as well as healthcare in the community itself. To compare this with influenza is something that is incredibly useful because, as I mentioned before, despite all the social distancing and mask wearing, the COVID surge has continued. But these public health measures are incredibly effective for influenza and another respiratory virus called RSV. And what I've done here is show you the Stanford Hospital experience in the previous 4 influenza seasons from September through January. And you can see that every year we have 300 to 400 to almost 500 cases in this 4-month period. And this is the last 4 years. Look at this season, a total of 2 cases of influenza since September, which indicates that mask wearing and hand washing and social distancing and all the other things we're doing, although it may not work well for COVID-19, it helps. And it is dramatically useful for eliminating influenza and RSV outbreaks from the community. The other thing that's been in the news, and I think it's important to mention in the context of thinking about these vaccines, is the variations, the mutations that have been described in the coronavirus from other countries, but now appearing in this country. It's important to realize that these mutations go undetected unless you specifically look for them. The standard testing we do for coronavirus, for COVID-19, does not pick up mutations at all. It's a very sophisticated genetic sequencing technique that's required to look for the mutations. And this is only done at the CDC and a few specialty and research laboratories throughout the country. So not only is it an uncommon thing to find, but it is also a delay in finding. So if we find that we have these variants in the community, these are variants that we're looking at from a month ago because it takes time to figure all that out. And it doesn't really reflect what's happening today. So my guess is that since we've had 8 or so cases already picked up in the state of Connecticut, it is prevalent throughout all our communities. And it's very likely that we will see another surge as these strains become more prevalent, because one of the features, whether it's the UK strain or the South African or the Brazilian strains, they are more communicable, more transmissible, more infectious by a factor of almost 2. They don't seem to be more virulent, although that's being discussed, and the vaccines seem to be still effective against these new strains, although mutations as they occur may affect that over time, and that is something we will have to watch very closely. So there are a number of vaccines in clinical trials, as you are aware. In fact, in phase 3 trials, there are 20 some vaccines currently in the research setting. There are several that have been authorized by the FDA and some approved in other countries. In terms of what's available in the US, as you know, it's the Pfizer and the Moderna vaccines at the moment. These have the same platform. They are mRNA vaccines. They have been approved in some countries, and obviously in the US, we just have emergency use authorization, not full approval yet. The next two vaccines coming down the pike are the Oxford AstraZeneca and the Johnson & Johnson vaccine. These have been applied for emergency use authorization in the country, but obviously they are not yet available. They ultimately work by mRNA production, but instead of the mRNA being administered in what we call a lipid nanoparticle, which gets it into the cell, the Oxford and the Johnson & Johnson vaccine are linked to a non-replicating adenovirus, which allows it to get into the cell. This extra adenovirus linkage is the means by which the mRNA is delivered. In all four of these vaccines, the mRNA directs the cell to produce spike protein, which is the business end of the coronavirus, and then your immune system responds to that spike protein, producing antibodies, producing cells that recognize it as foreign, and that is your immune response, and that is what protects you going forward. The Moderna and Pfizer vaccines are out there now. Over 20 million doses have been administered. The clinical trials, Pfizer enrolled 43,000, Moderna 30,000, a slightly different age group, but they all involved similar numbers of minorities, individuals with comorbidities, and median ages were about the same. And about a quarter of the patients were over 65 years of age, which is important because we know that the morbidity and mortality in COVID-19 almost exclusively involves people over the age of 50 and mostly over the age of 65. And the fantastic thing about these vaccines was that they were equally effective, 95% effective. When the vaccines were in trial, Dr. Fauci and others said, we'd be happy with 60% or 70% effectiveness. To get 95% is really incredibly valuable. Admittedly, these are two-dose series, slightly different from vaccine to vaccine, but they're well tolerated and very effective, as I mentioned. The side effects are generally mild. Injection site reactions are very common, pain at the site of injection. And then the sort of constitutional symptoms that you see after a flu shot: fatigue, headache, muscle aches, maybe low-grade fever, and that's about it. The serious adverse events, that is those same kind of events, but serious enough that you have to maybe stay in bed for a day or take off a couple of days from work, less than 1% in the combined series. So pretty well tolerated. These are the graphs from the Pfizer trial and the Moderna trial, and I just put these up to show how dramatically effective they were and how you could superimpose the graphs of one vaccine on top of another. The placebo group, the group that got just saline and no active vaccine, continued to see accumulating numbers of cases of COVID-19. Whereas the vaccine group in both studies, those curves were pretty flat. Very, very few cases of COVID-19 in the vaccine groups, and almost no serious cases. I think one serious case in the combined vaccine trials. That's 70,000 people. One serious case that ended up in an ICU. and no deaths from COVID in the vaccine recipients. The preliminary data on the adenovirus vector vaccines, the AstraZeneca on the top here and the Johnson & Johnson on the bottom, both came in at about 70% effective, not 95% effective in the prevention of symptomatic COVID-19. Now, all four of these trials really didn't focus heavily on the virus itself. They focused on symptoms and clinical diagnosis of COVID-19. So we know a lot about their efficacy in patients who get COVID-19 in terms of effectiveness and severity of illness, and it prevents both of those. We don't know a lot about whether the virus can still cause silent infection in people who've been immunized, and whether that viral infection in an asymptomatic patient could still be a source of infection and spread to others. Preliminary data in the Moderna trial and in the Johnson & Johnson trial suggest that this is decreased by the vaccine. But the extent to which it's decreased, we're not sure yet. So we're still wearing masks and we're still socially distancing until those data really become more robust and we can make clear statements about infectivity and asymptomatic infections. Now, the trial data is the trial data, and that's what was used to allow emergency use authorization from the FDA. Since these vaccines have been out, as I said, we've given 20 million doses of either Pfizer or Moderna in the US. And we've accumulated more data on safety using the CDC mobile app called vSafe, which allows everybody who's gotten the vaccine, whether it's Pfizer or Moderna, to report their side effects to the CDC, and this has been compiled. And the data looks almost exactly like the trials, with nothing new really coming out in these aggregated reports through vSafe. The couple of things to comment about in terms of these reactions is that they are more common after the second dose than they are after the first dose. And they're more common in younger people than they are in older people. So the over 75-year age group generally tolerates these vaccines very well. If you're 30 or 40 and you're a healthcare worker, you tend to have more side effects. And for both groups, those side effects are more prominent in patients after the second dose. But as I said before, these are not debilitating. They do not require you to stay at home. Most of the time, if you need anything, you take a Tylenol, and they're very short-lived, usually 1 or 2 days at most. So pleasantly surprised to be well tolerated and also dramatically effective. The one side effect that just needs to be mentioned is the side effect of anaphylaxis. Anaphylaxis is a severe and potentially life-threatening allergic reaction that you've probably heard about. It's manifest by shock and breathing difficulty, and it can occur within minutes of exposure to something you're allergic to. In this case, we're concerned about these vaccines. This was discovered in the trials and more recently has been quantified. The risk is about 2 to 5 cases per million vaccinations with these vaccines. So a very low rate, but a little higher than we would see with influenza vaccine. 90% occur within 30 minutes. And we found that the correlates of the risk of anaphylaxis occur in people who've had anaphylaxis previously to injectable drugs or injectable vaccines. So that would be a contraindication to getting these mRNA vaccines. Not sure this would apply to the other vaccines that will be coming down the pike, but certainly if you have anaphylaxis to, a tetanus shot or anaphylaxis from a flu shot, I'm not talking about egg allergy, this is anaphylaxis from the vaccine itself, then these vaccines would be contraindicated. And we ask that question for everybody that comes here to get a vaccine. We would be cautious in people who have had anaphylaxis from other things, like other reactions to other vaccines or injectable drugs. But no precautions generally if you've had allergic reactions to eggs or pets or insect venom or latex. There is no real evidence of cross-reaction there. So um, we would generally observe after the injection for 30 minutes if we're worried about the risk. Otherwise, a 15-minute observation is generally all that we would do. And I must say, we've vaccinated 15,000 people so far, and we've not had any case of anaphylaxis to date. But we are certainly aware of that potential. So the vaccine has rolled out according to the CDC and the ACIP recommendations. The ACIP is the American College of Immunization Practices. It is the CDC's subcommittee that decides on the appropriateness of vaccines, the dosing regimens, the populations to be vaccinated after the FDA gives their emergency use authorization or their full approval. And Connecticut has followed the CDC ACIP recommendations, starting in the middle of December, rolling out in phase 1A. Phase 1A, which continues to be ongoing, is vaccinating healthcare workers. And in our case at Stanford Hospital, at Stamford Health, it would be all of our employees that have any kind of contact with patients. It would be healthcare workers that are unaffiliated with Stanford Hospital, but live in our community, both Stanford and surrounding communities. And we've certainly done healthcare workers that are from New Canaan, Darien, and Greenwich, and first responders, including EMS, police, and fire that function as first responders. That phase 1A lasted until we opened 1B. I shouldn't say lasted as, because we're still doing some phase 1A. But phase 1B, the next phase, started at in the middle of January. We started on January 18th. And the first component of phase 1B has been individuals over the age of 75. So we have been vaccinating concurrently 1A and 1B over the last 3 weeks. The next phase of 1B will be individuals between the ages of 65 and 74, and then frontline essential workers and other individuals with underlying medical conditions such as diabetes and obesity and heart disease will be the phase to come in after the 65 to 74-year age group. The general population will be later. And obviously the reason to phase in these groups is because vaccine supplies are limited and need to be allocated to those that are at greatest risk, those that would have the greatest benefit in terms of their own health or the function of society, such as delivery of healthcare. So 1B started up using the old hospital. We're fortunate at Stanford Health to have a new hospital. And we have retained the old hospital, and it became very useful in April when we had a massive number of COVID infected patients in the hospital. We actually used that building to manage some of our overflow from the new building. And now we're able to use the second floor of the building as our vaccination site. It allows us to do up to 1,000 patients a day, and we have been doing close to that over the last several weeks. Our long-term goal, together with in a partnership with the city of Stanford, will be to move much of this off-site to an even larger site, the Elmcroft Street site that used to be Pitney Bowes. That can accommodate 2,000 to 3,000 vaccinations a day. We would see this as being particularly useful when the vaccine is available to all members of the community, and we've got 50 to 100,000 people that need to be vaccinated. Our goal is also to ultimately get this into physician offices, but clearly the two vaccines that are currently available, the Pfizer and Moderna vaccines, which require complicated storage, freezing, and cold chain management, are not really suitable for physician office sites. So centralized locations and relatively small, few number of those are obviously where Pfizer and the Moderna vaccines are being administered at the present time. Our limitations are really vaccine supplies at this point in time. We have a dashboard, so this is our data as of February 1st. We have delivered almost 15,000 vaccines. So as I sit here today, February 5th, we're probably looking at around 16,000 to date, maybe more. And this represents 16,000 vaccinations in about 13,000 individuals. Realizing most of these are first dose, because that's when we ramped up into 1B, and a sizable number are the the second dose vaccine. We've got about 10,000 people scheduled going forward. Many of these are second dose, but some are continued first dose vaccines. The booking is pretty heavy, but we do open new slots every day. As from the previous day, we have no-shows or cancellations or double bookings. That allows us to open new slots every day. So if you're looking for a slot and you are eligible based upon the current criteria, just keep looking at our website and you'll find time that you can come in and get your shot, and they are by appointment. New Canaan vaccine coverage. This is data that is kept by the state of Connecticut. Every vaccine that we administer is actually uploaded to the state of Connecticut through a software program called either VAMS or CT-WIZ. We participated in that VAMS program initially, but it just got to be too complicated. It was too difficult for community members to schedule. So we've moved to a different system, which we call eClinicalWorks. It allows you to sign up directly on our website. But with that interfaces with the Connecticut State Department of Health program called CT-WIZ, and they tabulate vaccinations in order to know where we stand and how much vaccine we need. The town of New Canaan, for example, for age 75 and older, as of this, I believe, February 2nd, had 69% coverage vaccination of its 75-year-old population, which is great. Stanford, I think, is around 55% as of today. So kudos to the town of New Canaan and getting that vaccine out to the community. We anticipate, based upon the governor's comments yesterday, that we would be moving to the 65 to 74-year age group within 7 to 10 days from today. Lots of controversies, obviously. Most of the vaccine controversies have to do with shortages, with shots wasted, delays in getting vaccine out into the community. Who's first? Is it healthcare workers or the elderly or long-term care facilities? And then, when it's rolled out, how do you deliver vaccine in an organized fashion to reach the people that most need the vaccine? So I thought I would address a few questions sort of up front, so that we can then address some of these concerns, and then we can do specific questions that I don't address after the discussion. So one of the biggest concerns, particularly working in a hospital with lots of nurses, is the concern about being in a childbearing age and the lack of data to support vaccination of pregnant women or women who are of childbearing age and might want to become pregnant. And I think the bottom line is that these mRNA vaccines are not new. They've been around for 20 years in various forms, often in cancer research. They've been used in development of Ebola vaccines. There are no known problems with mRNA. It does not revert to DNA in your cells. It doesn't get into the nucleus. It is purely a vehicle to cause the cell to make spike protein, and then it degenerates. Having done its job, the immune system then responds to the spike protein and has nothing to do with the mRNA. It is completely synthetic, the mRNA. Which is one of the reasons that you can make vaccines very quickly by synthesizing mRNA to mimic the mRNA of the virus. The vaccines contain no preservative. And the only excipients, if you will, in the vaccine, these mRNA vaccines now, are the lipid envelopes in which the mRNA is placed to deliver it to the cell in form of a vaccine. The lack of preservatives poses an issue because the vials that contain the vaccine have to be used within 6 hours of opening so that we don't get into any trouble with contamination. So that does limit the versatility of the vaccine. But certainly it's nice to say these vaccines have no preservatives, because that's always a concern in pregnancy. The American College of Obstetricians and Gynecologists and our local obstetricians are very proactive about this vaccine. We know that pregnant women, particularly in the later trimesters, are very vulnerable to COVID-19 and the high morbidity and even mortality that accompanies COVID-19. So at-risk women who are pregnant or who are working in healthcare should strongly consider getting this vaccine to protect their health. There is no evidence of any effect on the fetus. There's no evidence of any effect on fertility. And we now have over 15,000 pregnancies registered in VSafe after having had vaccines. So more data on safety will become concrete as we go through the next few months. Concerns have been raised that, my cultural background or beliefs don't support me getting vaccinated. There's no religious belief that should prevent getting this vaccine. There's no evidence that there's any specific risk in any race, gender, or age to this vaccine. And in fact, the vaccines were equally effective across all races, all genders, and all ages, which is different than the flu vaccine, for example, which we know doesn't work very well in the 70, 80, and 90-year-old that really needs the vaccine. That does not seem to be the case with these vaccines. They seem to work equally well at multiple ages. The other thing that's raised often is, if I still have to wear a mask and social distance and minimize my social gatherings, why bother getting the vaccine? It doesn't really change my life. Well, the vaccine saves lives and it will prevent you from getting infected. So I think the risk benefit is very clear. And if you do get COVID-19, having had the vaccine, it's very clear that you are protected from severe disease and from being in an ICU and ending up on a ventilator. One case out of 70,000 patients entered in those trials who got vaccine ended up at that level of severity. So profoundly effective vaccines to protect your health. The concern about side effects. My friend was very ill after getting the shot. I don't want to feel that way. And I think I emphasize that this is a pretty safe vaccine with less than 1% severe side effects. Very common local soreness after the injection. An occasional headache and fatigue, but the last 24 hours responds to simple medications like Tylenol or ibuprofen and is rarely disabling so that you have to take a day off of work. When we started out with this vaccine, we thought we should stagger vaccinations in our staff, because if we vaccinated all of our cardiology nurses or all of our intensive care physicians and they got sick from the vaccine, we would have trouble staffing. That has not happened, and it did not happen. And so we've really stopped even focusing on staggering vaccination. A concern that there isn't enough time to have understood the side effects because the vaccine was developed so quickly. I think it's important to realize that the vaccine was developed quickly out of an imperative because of the pandemic, and that the speed with which the vaccine was developed was not for lack of enrollment, but was for compressing all of the waste time in the usual development of a vaccine, eliminating a lot of the red tape, and actually making vaccine while it was being tested. Normally, you'd test the vaccine, then you'd wait for the FDA, and then you'd start to make the vaccine. Whereas it was done concurrently here. The risk being, if the vaccine didn't work, you've got billions of doses of vaccine you have to throw away. That was the risk. But the government sort of insured that risk by buying the vaccine in advance. It would have been money lost by the feds, not by the manufacturers. So that was how this vaccine development was compressed. Concerned that I don't need the vaccine because I already had COVID and I can't get it again. And that is actually false, because immunity after natural infection seems to be short-lived. And we know people can get reinfected. Certainly after 3 months, we see reinfections happen. Not tremendous numbers, but we see this on a consistent basis. So it is recommended that if you've had COVID, that you get the vaccine. I generally recommend that if you've had an asymptomatic infection or been very mildly ill, you can get that vaccine within 2 to 4 weeks after you've recovered. If you've had a bad case and you've been in the hospital, sometimes it might be beneficial to delay that vaccination so that your reaction to the vaccine is not exaggerated. We've seen people have perhaps more severe constitutional symptoms if they're vaccinated within a close interval from when they had a severe case of COVID-19. So up to 90 days would be preferable in that situation. And I sort of addressed the issue of the speed with which the vaccine was made. But it's certainly true that the vaccine evaluation for safety only goes now up to 6 months. So lots of things in place to evaluate safety going forward over the next several years using the cell phone app that I mentioned, VSafe, using the voluntary internet reporting called VAERS, which is the Vaccine Adverse Event Reporting System, which is co-managed by the CDC and the FDA. And you actually can report your own side effects using that system. Anybody can do that, whether it's a patient or an independent person or a provider. So you should be aware of that site. Concerned about difficulty getting it on the schedule? Certainly, the vaccine supply has created the problem of scheduling, particularly for the second dose. That was an issue with VAMS, which we have sort of discarded, and we're now using our own eClinicalWorks software system to do the scheduling. When you come in for your first dose, we don't let you leave without having an appointment for that second dose. So we've resolved the second dose issue that's so commonly been raised. There are some unanswered questions. Duration of immunity, we still need answers to. I talked about the asymptomatic infection, possible residual risk of communicability despite vaccines. The second dose can actually be spread out. It doesn't have to be 21 days for Pfizer and 28 days for Moderna. You can actually delay that second dose for up to 6 weeks. CDC says even you can go beyond 6 weeks, but our recommendation is generally within that 6-week period. The UK is actually experimenting with pushing out the second dose to up to 6 months and actually mixing vaccines, which the FDA has frowned upon, but lots of things coming down the pike in terms of nuances of dosing, timing, the possibility of needing booster doses, etc. And the safety questions, I think, we addressed. Very comfortable with the safety of this vaccine, the long-term value, and the benefits outweighing the risk, particularly in the middle of a pandemic, where we have a 2 to 4% positivity rate on every test that we do. So you can sign up to get your vaccine. This is the Department of Health website, the Connecticut COVID response. If you go onto the connecticut.gov portal /coronavirus or /coronavirus, you click on the coronavirus vaccine link, which will bring you to the field where you put in your zip code. The zip code then shows all of the possible vaccine sites within 10 miles of your zip code. You can then click on whichever site seems most convenient to you. You will then get a description of the site where you can then sign up on that site to get your vaccine and make an appointment. All of this is by appointment. Most places do not offer walk-ins because we need to account for vaccine. We need to be sure that we have appointments and pre-register because the paperwork, if you will, accompanying this vaccine is not like a flu shot, where you walk in, you get your shot, you go home. We are required to collect some demographic information, to report this to the state, every single dose. So it is a more complicated arrangement. The Stanford Health website has a similar process. If you go onto the Stanford Health website, stanfordhealth.org, you'll see the COVID-19 link. Click on that to the schedule. Click on that to book an appointment, and then you'll verify your eligibility and book an appointment. And it is as simple as that. If all appointments are booked for the day, you'll see that there may not be anything available, but as you try that the following day, you'll see slots appear and you can readily book your vaccine. Eligibility today is that you have to be in phase 1A, that is a healthcare worker, long-term care facility, or EMS community provider, or you're a community member over age, equal to or over age 75. In addition to that, you have to be a resident of Connecticut or you have to work in Connecticut. The state does not want us vaccinating residents of New York unless they work in the state of Connecticut in phase 1A. And so it's important to realize that your residence is important. And that's because the state vaccine supplies are allocated based upon the residence of the individuals in the state. So Connecticut gets vaccine supplies proportionate to its population, not proportionate to its surrounding population. So there is a residency requirement for candidates to be a resident of the state of Connecticut. This is a big lift to generate these mass vaccination programs, and I must give credit to all of our staff, from the HR folks to the security folks to marketing to the nursing staff that does the vaccinations to our laboratory and our pharmacy staff that monitor the outcomes and provide the vaccines and manage the vaccine so that we don't waste vaccine. This is a big team effort. Over 200 people are involved in administering this vaccine on a daily basis, but we think it's the right thing to do. We want to get vaccine out to the community because it is probably the only way this pandemic is going to be controlled. And with that, I think we've hit some highlights, and I'm happy to answer any questions.
The Q&A, Dr. Parry.
Yep, so I see the Q&A, and let me put on my glasses so I can read it. Okay, question relates to the definition on age. If I'm going to turn 65 in September, but I'm not 65 now, will I be eligible for the next phase of 1B? And the answer to that is not until you turn 65. It's unfortunate that, you're close, but the age limits are so easy to define, and they are what they are, and we have to follow what the state tells us to do. In fact, there have been numerous instances where sites have deviated from these recommendations and have had their vaccines confiscated. So unfortunately, there are limits, there are definitions, and we will follow those to the best of our ability. The second question, are you vaccinating people from Westchester? And the answer is not unless you work in Connecticut in phase 1A. So if you are a healthcare worker, or you work in a long-term care facility, or you're an EMS worker or police, fire, you live in Westchester County but work in Connecticut, you can be vaccinated. Yes, you are eligible in that setting, but otherwise the answer is no. So find a place in Westchester County. There should be one. And I do understand we've wrestled with this because we have a lot of patients from Westchester County who get their care at Stanford Hospital, who have physicians in Stanford, and that's their uh, primary site of care. And we've wrestled with the state on this, but they are at the moment unyielding, and so we are following the state mandate uh, not to vaccinate Westchester County residents unless they are simultaneously healthcare providers and work in Connecticut. What is the ECW system for scheduling? ECW is an electronic medical record. It is what we use for our outpatient medical records, and is what we are using through a system called ZocDoc, which is another software program, so that we can facilitate easy scheduling for members of the community. It turns out it's a little more difficult on the provider side for documentation. Um, Compared to VAMS, which was easier for us, but harder for patients. This is easier for patients, harder for us. It also allows us to bill insurance for administration of the vaccine. The vaccine is free, provided to us, but we do bill, as most sites are billing, for administration of the vaccine through insurance that does pay for administration. VAMS we are not using now, but we did take all of the individuals who signed up in VAMS to get their vaccination at Stanford Hospital, and we transferred all of those appointments over to eClinicalWorks. So we should not have missed anybody who signed up in VAMS. They should have received a call or an email that their appointments had been transferred into eClinicalWorks so that they could come here and get their shots as they had planned to through the VAMS schedule. What vaccine would you recommend for those with moderate to severe autoimmune disease, and how severe are the side effects for this comorbidity? Both the Moderna and Pfizer trials enrolled people with stable autoimmune disease, stable immunosuppression. And the data there were equally effective, and not much to choose between the two vaccines. So I don't think that the choice between Moderna and Pfizer is significantly different. We get what we get from the state. It actually doesn't come from the state, but the allocation is from the state. The vaccine comes from the manufacturer. So whatever we have available, we use. We obviously, for second doses, give what you had for the first dose. So that does constrain us a little bit. But for first doses, we can use either vaccine, whatever we have available. And I think that they are interchangeable for a first dose. And whether you have autoimmune disease or not doesn't really impact that decision. The next question is a never mind. I guess I anticipated that one. Is there an opportunity to choose? Yes, you can certainly request if we have that availability. We frequently will allot Moderna or Pfizer as the first dose vaccine for that day. We do that based upon the amount of vaccine we have, and also to avoid confusion at the site of administration. We like to have one nurse station giving one vaccine, if at all possible. So that one nurse is giving Pfizer all day long, they're not giving Pfizer, then Moderna, then Pfizer. This is obviously just the normal way anybody would eliminate errors in vaccination. But we often are dealing with both during the day because second doses need Pfizer and first doses may need Moderna. So you can ask, but I can't guarantee that that would be possible. When will teachers be eligible for vaccine? Well, certainly teachers who are 75 and older will be eligible now. Teachers who are 65 to 74 will be eligible in the next round of vaccine releases. And the essential worker group, which would include all other teachers, is planned to be the enrollment group after the 65 to 74 year group. So there are these stages to the phased rollout, and teachers come a little bit later, unless you're fortunate enough to be 65 or older, in which case you move up a category. I'm 64 and have asthma. Could I be part of 1B with underlying conditions? Yes, that group is again going to be coming. And I'm not sure the state has really decided whether after the 65 to 74-year age category, there's a blend of essential workers and 64 and below with comorbidities. I'm not sure that's been decided yet. If it has been decided, I'm not really sure what the answer is to that question, but that will be a state determination. The state has been following CDC recommendations, and so that's what we will do at Stanford Health as well. Is there a standby list if there are people who haven't shown up for their appointments? And the answer is yes. We have a pretty robust policy for waste management or waste mitigation, if you will. We try to approach this in a fairly structured way. As you know, these are multi-dose vials. The Moderna vial has 10 doses. The Pfizer dose has 5 doses, maybe 6 doses. And so as the day goes on and we have an hour left, we look at how many people there are to vaccinate. We look at how many open vials we have, and we start to use up the vials so that by the end of the day, we try to only have a dose or 2 left. And for most days, we succeed. We do have a list. We have a list of first responders. We have a list of our staff, healthcare workers, both of whom qualify under 1A. We have an inpatient list who are over 75, who we are trying to incorporate in that list. So we have yet not had to go below that group, but certainly we'll expand the list as we need to in order to use up all of those extra doses. If we have used up all our doses and we've got 2 people left, we will try and reschedule them for the next day so that we don't have to open up a brand new vial. So lots of elements to the waste mitigation. We're certainly acutely aware of it. We don't want to waste any vaccine, and we do have ways of dealing with that. We don't at the moment have a list open to the public. We may get there after we've vaccinated everybody in phase 1A. But we have people in phase 1A who decided they really weren't sure they wanted vaccine, and we're actively trying to recruit them to get vaccine. So we continually have a supply of people who in 1A still need to be vaccinated. When do you expect 1B to open up beyond the current 75-year and over age group? We are told by the governor that it's going to be within the next 7 to 10 to 14 days. And, you know, that will be when it is. So we'll wait for that announcement, which we expect perhaps towards the end of next week. My mom is 90 and will have hers on 223 at the 5th Street Clinic. She has a history of anaphylaxis from contrast, CT scan contrast. Does this clinic have emergency drugs? It should. Every vaccination site certainly been well educated about the possibility of anaphylaxis. Most CT contrast material or IVP contrast material is an anaphylactoid reaction. It's not true anaphylaxis, so the risk is probably quite low, but that period of observation should be 30 minutes. EpiPens should be available. And most anaphylaxis, if it were to occur, could be well managed in most settings. We have at Stanford Health felt that the drive-through concept is a little risky, so we have not implemented that. We have the emergency room close by if we need it. Our Tully site has the immediate care center close by if we need it. We have been fortunate not to need either one of those for anything that has been serious, so we're thankful that we are prepared. I'm a 63-year-old retired CNA, still helping family at Edge Hill. Am I a candidate? You are, if you're not in direct patient care, even though you are previously a CNA or a nurse or even physician for that matter, you probably don't qualify under 1A. If you're giving care to a family, we ask to state this specifically. If you have a license as a caregiver, you're a home health agency, you're a home caregiver, but you do that as part of a licensed job, then you do qualify under 1A. If you don't, they say that you do not qualify, you're not eligible because you take care of a family member, for example. There's certainly elements of that you could argue with, but that's the current regulation, and so that's what we have to follow. As more vaccines become available, do you envision recommendations varying for different age cohorts? I think that's very possible. That's a good question. I'm very interested to see what the ACIP will say when we have Moderna vaccine, Pfizer vaccine, AstraZeneca vaccine, and Johnson & Johnson vaccine, and different levels of protection from different levels of vaccine. How will they be deployed? I'm not sure. I think it's a very good question. And obviously, I and many other epidemiologists and infectious disease physicians and institutions will be looking for guidance to the CDC and the ACIP for how these vaccines should be deployed and how they should be applied differently in different populations. It may be that Johnson & Johnson's vaccine or the AstraZeneca vaccine is the perfect vaccine for the low-risk, younger individual coming to a pharmacy or physician offices for a single shot, although the AstraZeneca is 2 doses. And it may be that the more effective vaccines like Pfizer and Moderna are reserved for the higher risk folks like the over 65 population, the comorbidities, the long-term care facility residents, etc. But we'll have to see how that is planned by the ACIP. I've heard that Moderna is not quite as effective in adults over 65. Moderna and Pfizer are equally effective, 94 to 95%, no statistical difference between the two, and no statistical difference between the under and over 65-year population between the two. 94, 95, I think, are the break points, and they are the same. So I think that answer is no. Should one register on both the Portal Connecticut and coronavirus and the Stanford Health? No, you don't need to register on both. You can register on the Stanford Health website. You do not need to register in addition on the Connecticut.gov website. They will generally direct you to another site to be registered, but you don't want to double book because then we have lost appointments and redeploy vaccines, and it makes it difficult. If you've got an appointment, you should be good to go. Timing of recurrent second shingles vaccine and the initial COVID vaccine. That's something I didn't touch on. It's a good question. The CDC recommends that a minimum of 2 weeks separate vaccines in this setting. So if you've got a COVID vaccine today, you should not, and you have a second dose booked a month from now, you should wait for your second shingles vaccine or your any shingles vaccine for at least 2 weeks beyond the second dose or before the first dose. So you're not faced with competing immune commitments, if you will. My own advice has generally been to wait a month between different vaccines, because with live vaccines, there is a month requirement between them. These are not live vaccines, but certainly I like to have a simple rule, and I've never really found that you go wrong by waiting a month between vaccines. But the official recommendation is 2 weeks. Hours of operation, the Stanford Health operation is open at by 7:30 in the morning. And we have been going most days until 7 o'clock at night. So it's a 12-hour operation, and we've been doing it 7 days a week. How do I prove my comorbidities? And that's a question that I can't answer today. That's something that will be they'll be strategically answered by the state when comorbidities are part of the eligibility criteria. At the moment, they are not. You're in 1A, it's your job function, it's where you live, and whether you're in a long-term care facility. And in phase 1B, are you 75 or older, regardless of comorbidities? So that will be defined, and how would you prove that will be defined. And I don't know the answer to that question at this point in time. Do you have to wait 7 days post Pfizer number 2 or 14 days until you're fully protected? And this is specifically for the Pfizer. And that's an interesting question because the two studies, Moderna and Pfizer, were designed somewhat differently. The Moderna trial, you got 1 dose of vaccine, you got a second dose at 4 weeks, and the data started to be collected 2 weeks after the second dose. With Pfizer, you got 1 dose of vaccine, your second dose was at 21 days, and then they started to count protection 7 days after the second dose. So it's a little different, but I think the bottom line is within 7 to 14 days after that second dose, you're protected. And if you look at those curves that I showed you closely, there is beginning protection at 2 weeks after the first dose. We wouldn't guarantee it until after the second dose. And the durability of protection, we don't guarantee until after that second dose. And there's still an asterisk out there. We don't know whether you'll need a booster dose in a year or 2 years. That will be determined. But we've been through this before with the shingles vaccine, with the pertussis vaccine, with the pneumonia vaccine, learning that booster doses are needed at a later date after introduction of the vaccine. So this is not new. This is the way we learn about vaccinations and the need for booster doses as time goes by. Does the one-shot vaccine hold greater hope for the larger part of the world? I'm a little bit concerned. Excuse me. A little bit concerned about the one-shot vaccine. The reason I'm concerned is that if immunity is partial after a 1-dose vaccine, there may be an increased risk of mutations. We know that certainly in the bacterial world, if you give a small dose of immunity or a small dose of an antibiotic, you tend to promote resistance. And there's a sense that if you partially immunize or partially treat a viral infection, you also promote resistance and promote mutations. So I wouldn't want to do that with this particular virus because just like influenza, mutations impact the value of the vaccine as we go through the seasons from year to year. We don't know enough about the potential of the coronavirus yet to mutate to a point where it becomes resistant to vaccines. But I think the goal is to vigorously immunize everybody to the maximum ability, while at the same time getting vaccine out to as many people as possible, but not to under-immunize the population on a case-by-case basis because of that somewhat theoretical risk, but certainly concerned that mutations are promoted by under-immunizing individuals. It's a very controversial topic, and certainly the United Kingdom has promoted giving single doses to a larger number of people and withholding second doses. Nobody really knows what the right answer is, but the theories abound, and hopefully we'll know as time goes by what the right answer and the wrong answers are.
Well, thank you, Dr. Parry. This is a great talk. We've got just so much great information. And we will be posting this on our website for all that have missed it. But again, thank you, Dr. Parry.
Okay, thank you, everybody. Stay well. Get your vaccine.